Well, I only just found that there is no cursor or arrow or laser pointer, and so you'll have to bear with me with a couple of slides where I really could use a pointer, and I guess sometimes low tech is better than high tech. I should have almost always travel with a pointer, but in any case, welcome. I have a lot to cover. Try to talk about evaluation management of fatigue in 30 minutes is next to impossible, but I'll try to give you some ideas. People generally ask for ideas that they can take back to their physicians and new things to try or new things to ask about. I'll give you some sort of basic principles rather than dwelling a lot on details. I will discuss some off-label uses of medications. I don't have any conflicts of interest to disclose. So you'll hear a few recurring themes in my talk. One is that everybody's different, and if you're going to evaluate somebody with fatigue, you need to go through a fairly detailed history and examination, a variety of testing, to try to figure out what the major drivers of fatigue are in that individual patient. And of course, that's critical because your treatment is going to be based on what your evaluation turns up. So important that physicians and their patients are sort of on the same page and that goals of treatment are similar. For me, goals of treatment usually are reducing symptoms, improving functional capacity, and improving quality of life. Many factors contribute to fatigue, and that's why there's no way I can do this in 30 minutes. But the big three tend to be pain, poor sleep, and depression. Autonomic nervous system dysfunction is something that I've spoken about, Dr. Raj will speak about, that actually can cause fatigue and can actually make it worse also. Variety of metabolic factors can contribute to fatigue. I'll just touch on a few. Inadequate rest is a surprisingly common problem because in modern society everybody is driven to succeed, and people feel guilty when they take a break and rest, and often just having permission to say, okay, this is my downtime, I was just busy, now I have to have a break, is important to people to conserve energy and manage their fatigue. It's important to recognize that cognitive tasks are just as tiring as physical tasks when you're tired and trying to sort of budget your energy. Emotional stresses are very draining, and the stresses of everyday life tend to suck up energy. For me, living in the Washington, D.C. area, driving anywhere at any time can be exhausting and stressful. So this is sort of pictorial graph of the vicious cycle and how each one of these major factors kinds of feeds into the other. And the major point that I want to make here is that because these things are aggravate each other and interact with each other so much, they have to be treated together. So essentially, as long as you're in pain, fatigue won't get better, your sleep quality won't be good, and it'll be hard to get your depression under control. As long as you're depressed, you're going to be more sensitive to pain, you're not going to sleep well, you're going to be tired, you're going to have cognitive symptoms. Again, we come back to the idea there's no magic formula, there's no one thing that's going to work for everybody. This is a cartoon that I think shows that very well. The television commercial says, ask your doctor if taking a pill to solve all your problems is right for you. I wish it were that easy. Again, we come back to everybody's different. No two people have identical symptoms. Even if two people did have identical symptoms, their response to those symptoms, their response to treatment would be different, depending on a variety of psychological factors and physical factors. At the bottom, I'm particularly interested in pharmacogenetics and how different people respond to medications differently. So obviously I'm not the first to make this point, but this is a quote from Osler that's more than a century old. Variability is the law of life, and as no two faces are the same, so no two bodies are alike, and no two individuals react alike and behave alike under the abnormal conditions we know as disease. So with deference to my learned colleague, Dr. Klaw, broad sweeping generalizations may apply to most people, but maybe not necessarily to you. Again, we come back to the vicious cycle, and so I'll talk about each one of these a little bit more in detail, and then talk about a few minor few less important contributors, but common ones to fatigue. So pain, for those people who live with pain, I think this is pretty obvious, but for people who don't, why does pain cause fatigue? Well, just being in pain saps your energy. Pain limits your activity, and the more you sit around, the more tired you become. Again, Dr. Claw alluded to just being active helps. Pain can disrupt your sleep. Pain tends to contribute to depression. So there's lots of ways in which pain tends to cause fatigue. One of the problems with managing pain is a lot of people in chronic pain will say things like, well, it's not that bad, I'm used to it, I've learned to live with it, I don't want to take pain medication. Nowadays there's this big societal thing about taking pain medication. These kind of approaches, unfortunately, are not really helpful to managing chronic pain. Just as Dr. Claw talked about the idea of central sensitization and the idea that pain over time can sort of hurt more and more and more. You may have the same, if we could measure how much pain you're having, that may feel like a 7 to you, and that same amount of pain might feel like a 3 to me. But conversely, I see people have the opposite problem, that they become, in a sense, desensitized to pain. They get so used to being in pain that they don't notice it anymore. And they will tend to, I see more patients who underestimate how much pain they're in than people who say, oh gee, I'm in so much horrible pain and I can't see why they're having so much pain. The other thing that's important to recognize as somebody interested in the autonomic nervous system is your body typically makes adrenaline in response to pain. It's a fight or flight thing. If a wild animal is chasing you and you're trying to run, you don't want to feel tired and you don't want to feel pain. So some people figure that out, and they realize that as long as they can keep their stress levels up, it doesn't hurt as much, and their fatigue isn't as bad, and their depression isn't as bad. But then, of course, when the stress goes away, when the driver of adrenaline goes away, they crash. So an easy trap to fall into. So another problem we have with pain is how do we know how much pain you're in? We ask people, gee, on a scale of 1 to 10, how bad is your pain? But people can't, the answers they give are not helpful. I see people who underestimate their pain. I see people who overestimate pain. We examine people, we poke them, we say, gee, does that hurt? I've always joked that it would be helpful if we had some kind of painometer where you could just stick your finger in this device and it would tell you what your pain level was. So I won't go through the details of this, but just this spring, there's a very interesting study published where they looked at biomarkers. They looked at proteins in the blood, and they were able to find that in patients who were in pain had certain chemicals in their blood that pain patients didn't, and there was a trend toward if your pain was worse, then you had higher levels of these things. So the potential that at some point you might go into an emergency room in pain, they don't believe you're in pain, they could do a blood test and say, oh yeah, you really are in pain, or even that the patterns of these different markers might be predictive of which type of treatment might be more effective for you. So I find it helpful to think about pain in sort of different categories. So this oversimplifies a little bit, and some pain obviously is of more than one type, but inflammatory pain typically responds to anti-inflammatories. Those are usually the NSAIDs. In Ehlers-Danlos patients, inflammatory pain primarily is the pain of muscle strain, muscles around loose joints straining, trying to hold those joints together. But in general, inflammation tends to be a small component in pain, and most Ehlers-Danlos patients recognize and are reassured to know that there's a reason why anti-inflammatory medicines don't work for them. Most of the pain in Ehlers-Danlos patients tend to be what I call mechanical pain. It's the chronic strain, it's the tightness of things pulling on things that don't like being pulled on. And they're non-pharmacologic, that's why non-pharmacologic measures are so helpful, and Dr. Claw talked about that quite a bit, as well as muscle relaxants. And then neuropathic pain has a different quality and requires a different approach to treatment. Again, a list of medications that Dr. Claw had also mentioned. Again, this is not all about taking pills. There's a lot of non-pharmacologic measures that are helpful for relieving pain. So this I thought was too good a cartoon to pass up. This is patient getting a massage, and he says, be careful, I'm worried the knots are the only thing holding me together. So just a word of warning for physical therapy and massage and things like that, and somebody who's a little overzealous at trying to get all the knots to relax may do you a disservice and leave you with sort of unstable joints and more pain. Medications for pain, I'm not going to go through this in detail. I put this slide up mainly to make the point how short the list is, that if Tylenol doesn't work for you and the anti-inflammatories don't work for you, and you try duloxetine or Savella and they don't work, or you have side effects, and you try gabapentin and Lyrica and they help a little bit but you're still in pain, then you're left with topical medications, and then you're left with opioids. So even though there may be good scientific evidence about why opioids don't work in certain types of chronic pain, they do work in certain types of chronic pain. And so I think to say, that fibromyalgia patients don't respond to opioids might be painting with too broad a brush, because I see patients in whom opioids do help. And then, of course, in this country, cannabinoids are available in some states, and they have a lot of potential for helping mood, fatigue, pain, a lot of issues related to fatigue. So depression, you'll see the recurring theme, same idea as pain. A lot of people don't realize they're depressed. Some people who do say, well, of course I'm depressed. Wouldn't you be depressed too? My depression isn't that bad. I'm used to it. I can deal with it. Counseling isn't going to help me. I don't want to take antidepressant medications. They'll have side effects. That's not really helpful, because again, thinking back to the vicious cycle with the blue arrows, if you leave your depression untreated, fatigue and pain and sleep are going to remain problems. And one really important thing about depression is to recognize that you don't have to be sad to be depressed. You don't have to be crying, gloomy, hopeless, the world's coming to an end, my future is bleak. Neurotransmitter deficiency can be significant even in the absence of clinical depression. You might not even meet the DSM-5 criteria for clinical depression, but even if you have sort of a subclinical depression, that can be a big factor in fatigue, pain, and sleep. Again, this isn't all about taking medications. Non-pharmacologic measures for management of depression can be very helpful. And this was a slide I couldn't pass up. Somebody choosing the huggist over the druggist, and make the point that, yeah, sometimes if you're feeling a little bit down, that just a hug from a friend or a family member or a pet or even your favorite stuffed animal can make you feel better faster and with fewer side effects than taking pills. So, approach to depression, I found it helpful to, sort of like pain, to divide depression symptoms into groups. This is sort of an oversimplification, but for a lot of people it's very helpful. Depression symptoms fall very roughly into three groups. And this is shown on this Venn diagram that I borrowed years ago from a pamphlet for a supplement called Deplin. And primarily I use this slide to show people, look, if you're depressed and you've been taking a serotonin type antidepressant, but you're still tired, you're still having trouble focusing, you still have no motivation, you still have no energy, that's really not surprising, because those are symptoms that are mediated by different neurotransmitters. And so you really wouldn't expect your serotonin type antidepressant to help with that. And again, people are very reassured by that. They're worried, they're scared that, here, I'm depressed and I'm taking an antidepressant, but I'm still depressed. What's wrong with me? The answer is, again, there's only so much you can expect from medication, but most people will need a combination of medications to address the various symptoms of depression. So, very similar cartoon. The patient goes back to the psychiatrist or to her family doctor, says, I think my dose needs adjusting. I'm not nearly as happy as the people in the ads. So, just to have realistic expectations that things are not going to go from dreary and gray to a field of sunflowers overnight. And then sleep, that sort of third leg of the stool, if you will. Same idea, different types of sleep problems require different treatments. Some people primarily have trouble getting to sleep, some people have trouble staying asleep, some people have trouble getting back to sleep when they wake up overnight. And very commonly in Ehlers-Danlos patients, they don't have any of those things, they just wake up in the morning feeling unrefreshed. So, just like pain and depression, In fact, almost worse sometimes is tell people don't realize how bad their sleep is. You know, I ask people, do you feel rested when you get up in the morning? And they're like, well, I guess so. Do you feel like when you get up in the morning you just want to roll over and go back to sleep for 2 more hours? And I say, well, yeah, doesn't everybody? Say, well, no, some people actually feel rested after sleeping. So a lot of people say, well, I've never slept well. I've been a bad sleeper my whole life. You know, I don't want to take sleeping pills. But leaving your sleep problems untreated, your fatigue is never going to get better. So maybe even more than depression, people tend to misperceive what's wrong with their sleep. The classic illustration is the person who says, I'm a great sleeper. I can sleep anytime, anywhere. I can sleep 10, 12, 14 hours, no problem. And I said, well, you know, I think that means you're not a good sleeper. And they say, no, I'm a great sleeper. And then we know that there are lots of people who have sleep apnea and lots of people who have limb movement disorders who are totally unaware of that. And sometimes, remarkably, even their spouses are unaware of it. And then the most common pattern, I'll show you in a minute, of sleep disorders that we see in Ehlers-Danlos patients is the problem of not spending enough time in deep sleep and having the continuity of sleep broken frequently by what we call arousals. And that type of sleep disorder doesn't really cause any symptoms except waking up in the morning feeling tired. So sleep studies are kind of almost a double-edged sword. I see so many people whose sleep studies are misread and they're sent down a treatment path that isn't right for them. They can be very helpful, but that's carefully interpreted. The newest generations of home sleep monitors are getting better. The latest iterations, the latest software algorithms and some of the so-called wearables have gotten pretty good. They're not highly accurate scientific instruments, but if your Fitbit shows that you're waking up 20 times a night and you start on a new medication and your Fitbit shows now you're only waking up 5 times a night, then your medicine probably is helping you. You're not going to wake up the first morning saying, wow, that's the best night's sleep I ever had, but over time, the quality of your sleep should be better, your fatigue should improve. So, and even in the absence of the fancier monitors, sometimes just if you have something that monitors your heart rate overnight, that can help, and I'll show you why that is in a second. So here's where I really miss my cursor or my laser pointer, but I'll try to walk you through this. The upper graph, these are sleep cycles during the night. So the green is light sleep, the blue is deep sleep, and the reddish brown color is REM. So you can see in the top graph that the person starts in light sleep, goes into deep sleep, then light sleep, then REM, then light sleep, then usually there's a little more deep sleep, then light sleep, then REM, light REM. So you see there's a cycle of going through the different stages of sleep with most of the deep sleep early in the night. By contrast, if you look at the lower graph, this is a typical sleep study in someone with Ehlers-Danlos who says, gee, I'm not waking up a lot at night, I'm not choking and gasping, I'm not thrashing around all night, I just wake up in the morning feeling like I haven't slept. And you can see that this person has no deep sleep, has essentially no REM, has nothing that looks like they're not cycling through the stages of sleep. What you can't see in this lower graph are the disruptions. So in the sleep lab, we define an awakening as a disruption to the continuity of your sleep that lasts more than 30 seconds. It turns out most people have to be awake for at least 2 minutes to remember having been awake. So this person remembered waking up twice, she actually woke up 23 times. If the continuity of her sleep is broken for less than 30 seconds, we call that an arousal. She had 125 arousals. So the continuity of her sleep was broken 150 times in 7 hours. And that's why she woke up feeling tired. So this is a cartoon where doctor's telling the patient the MRI reveals your head is riddled with conventional wisdom. I flip this the other way and say patients have to deal with physicians whose heads are riddled with conventional wisdom to make the point that this previous sleep study with 150 arousals and no deep sleep was read as normal by a board-certified sleep doctor. So what's really helpful if you're going to have a sleep study is what's called a hypnogram. And so again, I missed my pointer, but in a hypnogram, you get to look at sleep stages, heart rate, body position, breathing patterns, oxygen levels all at once. So you can see, okay, you know, this person, the top line is awake, so you'll see that there's a bunch of spikes that this person woke up 25 times during the night. And if you look at then the lines beneath that, you'll see that what correlates best with those awakenings are spikes in her heart rate. And if you look just to the left of both of these, you'll see that in the heart rate tracing, there's a line that's flat, that doesn't have a lot of spikes. And if you follow that up, you'll see that that corresponds with a nice period of deep sleep. The rest of the night is just constantly disrupted. So how do you manage sleep disorders? Again, don't overlook the non-pharmacologic measures. Good sleep hygiene means, you know, not doing a lot of other things in bed that are distracting. Big one is not having a child or a pet sleep in your bed with you. It surprises me how many people do that. Replace your mattress if it's more than 15 years old. People are sensitive to light and sound, so make sure you do what you can to make your room extra dark and extra quiet. And then, of course, if you have sleep apnea or a limb movement disorder, treat those, but only if they're significant. So medication, I just make the point here that medication regimens are going to be complicated. Most people are going to need a combination of things, something to reduce these arousals, something to maybe increase their deep sleep. A lot of people don't realize how much pain they're in overnight. A lot of people will need to take a pain medication overnight. And finding the right combination for each person can be a frustrating trial and error process, but when you do find something that improves the quality of your sleep, then all your other symptoms will get better. So I don't have time to go through all the list of the different types of medicines, but you'll have these slides. Just 2 sentences about the autonomic nervous system to make the point that the autonomic nervous system's job is to keep everything on an even keel. When the autonomic nervous system malfunctions, things fluctuate. For the purposes of this talk, if you look at the person on the right, these are simple in-office autonomic testing showing parasympathetic and sympathetic responses to different maneuvers, but just without all the details, if you look on the right and you look at the red line and think of that as being energy or adrenaline, that this person is overreacting to minor stresses and wasting the energy that they're trying to conserve. So this is how autonomic dysfunction actually can make fatigue worse. And again, this is just to make that point again, and to be careful with medications that we often use to try to treat autonomic dysfunction. If you take too much, can make your fatigue worse. So titrating doses is really important. So overall, obviously, different causes of fatigue require different treatments. Much of the fatigue in Ehlers-Danlos comes from poor sleep, chronic pain, depression, autonomic dysfunction. But of course, there are other things that need to be looked for too. Just again, go through these quickly. The common things that I see are micronutrient deficiencies, vitamin D, B12, and magnesium being very common. Hormone deficiencies, not well understood, but I see a lot of people who are deficient in testosterone, and I think that can play a role in mood and fatigue, as well as the very important role that they play in building muscle. Salt fluid imbalance is very common for anybody who has problems with lightheadedness on standing, and then mast cell dysfunction can contribute to fatigue also. The point to make about D deficiency, right, well, it may be hard to prove that giving people vitamin D supplements reduces pain. It also doesn't make sense to walk around vitamin D deficient, and the point that I make about D deficiency is correcting D deficiency takes a lot of vitamin D. So if your level's 20, normal's 30 to 100, it's going to take 1 million units of vitamin D just to get your level up into the 40s. B12 deficiency, just make the point that most commercial labs report a normal B12 level as 200 to 1100. Anytime you see a range like that, you have to sort of scratch your head. A couple people I saw this week, 231, 253. Those are not normal B12 levels for people who are not strict vegans. So if you're even low normal, there's no downside to taking B12 supplementation. The conventional wisdom people will say that oral B12 supplements are fine, you don't need to do shots. That's true of most people. I see some people who take oral B12 supplements and their levels don't go up at all, and so they do need to do shots. Magnesium, Dr. Claw mentioned, the point I'd make about magnesium is that, like vitamin D, if you're magnesium deficient, it takes a ton of magnesium to correct your deficiency, and because magnesium tends to have a laxative effect, you can't really take that much orally. So it's going to take a long time to correct your deficiency. Epsom salts and some topical oils and lotions are a good way to absorb. You absorb magnesium better through your skin than you do through your GI tract. And I mentioned testosterone deficiency. I won't get into the details of that. I'm still working on trying to find somebody who knows more about endocrinology than I do to sort of study this more carefully. But I found this a few years ago in working with several young women who were exercising a lot and not building any muscle. And in trying to figure out what the explanation for that was, I found that they were severely testosterone deficient. Salt-fluid imbalance, I have a bunch of slides here. The major point about salt-fluid imbalance I would make is that most people with orthostatic intolerance who are told to eat plenty of salt and drink plenty of water are not getting enough salt. Do you tell people you're dehydrated because you're drinking too much water? They don't, that doesn't make sense. But the way I usually explain this to people is every time you drink plain water, you're diluting out the salt in your system. The only way your body can get your salt levels back up are either hold on to salt or pee out the water you just drank. So if you're, no matter how thirsty you are, you're still lightheaded, no matter how much you drink, you're still thirsty, you need more salt. And I have a few slides about doing this. Mast cell dysfunction, Dr. Maitland's going to talk about, so I don't need to spend a lot of time on that. And then lastly, make a point about stimulants. I think Dr. Claw made the same point that if you're somebody whose blood pressure is chronically low and you need to take a low-dose stimulant to keep your blood pressure up, that's fine. That's totally different from taking stimulants to plow through exhaustion. If you're tired and you say, oh man, I'm really tired, but I really wanted to get this done today, let me just have some caffeine, let me just take a Sudafed, let me take an extra Ritalin and then I'll be okay, that's just going to make you crash that much harder when it wears off. That's really counterproductive. The exceptions are modafinil and armodafinil, Provigil and Nuvigil, which for a lot of people help with focus and concentration and alertness. Most people say it doesn't give me more energy, but they help me be more productive with the energy that I have. And these don't have issues with dependence and tolerance and withdrawal. You can take them some days and not others. They aren't physically stimulating, so you don't have a crash when they wear off. So how do you reduce fatigue? Basically, do a thorough evaluation, try to identify as many factors as you can that might be contributing to fatigue, and roll that all into a comprehensive treatment program. This is a simple slide. People ask me, okay, what do I have to do to get better? This is it. You need to get better, more. Think of your body as having an energy pool. Sleep is your big chance to put energy into that pool, and then all these stresses that you deal with every day are draining energy out. So if you can sleep better, if you can manage pain better, fatigue is basically a reference to pushing through fatigue, just makes your fatigue worse. So reducing the stresses that are energy drains and improving sleep will help your fatigue overall. And then we get the vicious cycle going back the other way. If you feel better, you're able to do more. If your pain is better, you're able to sleep better. If you sleep better, you have more energy. If you're more active during the day, you're going to feel better. If you're more active during the day, you're going to sleep better. And that is how fatigue gets better. So thanks for your attention. Always end by acknowledging colleagues who helped me along the way when other people thought I was nuts. And for my patients, for allowing me to sort of experiment on them and say, I can't quote you any literature that says that this works, but it works for other people, so how about we try it on you? And then lastly, this is a fabulous resource. Claire Smith is a mom who spent many years of her life compiling this unbelievably encyclopedic text and for those of you who are not familiar with this, it's available by single copy through the Ehlers-Danlos Society, and it's a great reference for patients to learn things from, and if you're lucky, you might even be able to get your clinicians to read relevant sections of it. So thanks for your attention.
Thank you so much. Okay, I'll jump straight in. Is melatonin a good idea? And if so, what dosage is recommended?
So again, I'll go back to different things work for different people. Melatonin is innocuous enough that it's worth trying. The physiology of melatonin is it's a signal to your body that it's dark and it's time to get ready for bed. So it tends to be, I've found it more helpful for people who have trouble getting to sleep, who have what I call the second wind, where they kind of drag through the day or drag through the late afternoon and early evening and then get a second wind at 9, 10 o'clock, and then they have trouble getting to sleep. Taking melatonin around 8-ish can help with those people. Dosing, again, is very individual. The standard dose of melatonin is 3 milligrams, but I've been told by people much more expert than I that it only takes 1/10 of 1 milligram to saturate all your melatonin receptors. So is the extra melatonin binding to something else? I have patients who say they need to take 15 milligrams of melatonin. I probably would start with the standard dose, and if 3 milligrams doesn't work, maybe double it to 6. I don't know that many people. Again, my success rate, the number of people who find is helpful, is probably in the 15% range, but it's something that's innocuous enough that it's worth trying.
Could you give us some more information about what dry needling is?
Dry needling. Well, I'm not really sure that relates to fatigue.
It was on one of your slides.
Oh, okay.
You mentioned.
Okay, guilty as charged. So dry needling is a physical therapy technique that involves inserting a very tiny, like acupuncture needle into areas of muscle spasm to get the muscles to relax. It can be quite painful, and in fact, if done well, it is quite painful because you're putting these needles into the fibers that are firing off pain signals. But it can often help relax chronically inflamed muscles. Often muscles will tighten up as a response to pain, and then you're stuck with pain causing muscle spasm causing pain. And heat and physical therapy manipulation and sometimes dry needling are good ways to deal with that.
Do you find that salt pills work the same as eating salt, or is one typically better than the other?
So the biggest issue with salt, as I sort of alluded to, and people ask, well, how much salt should I take? The issue is the ratio of salt to fluid. So if you're drinking a ton of water, you're going to have to eat a ton of salt. Generally, just sort of theoretically, if you're salt depleted, your body's doing a bunch of different things to try to hold on to salt. If all of a sudden you take like 2 giant salt tablets, your body say, whoa, wait a minute, there's tons of salt around. We don't need to be doing all these things to conserve salt. And then a few hours later, that salt you've just taken is gone, and you're struggling to try and hold on to salt again. So it makes sense to take, even salt tablets. If you do the salt stick capsules, I think have 250 milligrams of sodium in each one. So you want to space out your sodium during the day and not take 2 grams of sodium all at once.
Anything to help delayed sleep phase disorder?
Delayed sleep phase disorder. Yeah, that's a problem. And this is particularly in Ehlers-Danlos and again ties in with my thinking that this is autonomic dysfunction. So the classic story of somebody who, and we see this in the chronic fatigue syndrome patients too, drag through the day and then start to wake up at 10 o'clock at night, and at midnight, this is the most awake I've been all day, and there's no way I can get to bed before 2 or 3 in the morning. And that's really hard to reset. I mean, this is something where I've begged, people who are more expert at sleep than I am to say this has got to be a circadian rhythm problem. There's some underlying issue here that because we can sort of try to force these people to go to sleep earlier by saying, okay, if you're starting to kick in adrenaline at 9, 10 at night, your body's confused and thinks that's when you should be waking up. Well, then you can take some adrenaline blocking drugs to say, okay, body, I don't want to revved up, I want to be calmed down. Then you may need to take, in addition to that, you might need to take something in the Valium family, again, to sort of calm you down. What else? This is where some people do find a sleeping pill like Ambien can at least help to sort of set their bedtime and say, okay, body, this is, it's 11 o'clock, it's time to go to bed, it's not time to be waking up. But it's very hard. Frankly, I often in these books will often say, okay, let's try to get you a restful night's sleep between 2 and 10 or 11, and then we'll try to move your sleep back. But it's a difficult thing that we need better treatments for.
Do you have any recommendations for hot flashes during sleep that's non-hormonal?
Hot flashes during sleep that are non-hormonal. Well, hot flashes during sleep that are non-hormonal very often are autonomic. So the simplest, though not always true, distinction is hormonal hot flashes tend to be upper body, mostly chest and face. If you're waking up hot all over, that's an autonomic problem. Either regulating body temperature is one of the things that your autonomic nervous system is supposed to be doing. And if it's not working properly, your body temperature is going to fluctuate. And so you may very often in this roller coaster, if you remember the red and blue graph I put up, what often happens is body temperature will actually bottom out in the middle of the night, and then people will overcorrect. Their body will say, oh man, we're cold, we need to warm up a little bit. They'll warm up too much and they'll wake up in a hot sweat. Sometimes it's more obviously adrenaline. If you're waking up in a sweat and your heart is pounding and racing, then that's clearly autonomic, and medications like beta blockers to suppress the adrenaline will help. And the only other thing, small group people waking up flushed and sweaty in the middle of the night are going to be waking up because they've had a vivid dream or a nightmare or something like that. And there's different treatment approaches for that.
If an EDS knows they're having issues with sleep disruption, what type of specialist can they work with to try to treat it?
I wish I knew. Again, this is very frustrating that people ask me, where I am, can I recommend a sleep lab for them to go to? And I was like, no, not really. I've pretty much had trouble with all of them, and I've tried to explain to the sleep doctors what they should be looking for in these patients, and they still read the abnormal studies as normal. So I wish I had an answer for that. I think, the ideal would be go to see a sleep medicine specialist and either, take a copy of Claire's book or take something else that talks about sleep disorders and Ehlers-Danlos to say, hey, this is what, my doctor, I don't sleep well, and my doctor thinks I should have a sleep study, and I know that, these are the types of problems that most people with Ehlers-Danlos have, and so I want you to be looking for those when I have my sleep study.
When wearing wearables for tracking sleep, what do you think are the best ones out there right now? And if you're aware of it, what do you think of the Oura Ring?
Yeah, I don't know much about the differences among the couple. I know that I think last year the Fitbit folks updated their sleep algorithms, and so the Alta and the Charge 2, and I think there's a third one that have these new sleep algorithms in them. Otherwise, yeah, I don't, something I probably should study.
Okay, hang on a second. Does photodynamic therapy, red light therapy, have any benefits to those with connective tissue disorders and chronic fatigue?
I don't know, sorry.
No, that's fine. One big thank you to you that's come up. I would still not likely have a diagnosis if they hadn't seen your 2010 paper, and they can never repay you enough for that. One piece of feedback.
I wrote that paper on a long plane ride, and I never dreamed it would have the life that it had. Yeah, I just got a nice piece of fan mail from somebody in the UK who'd come across it and asked me if she could reproduce it and give it to people, and I was like, of course, that's what it's there for.
Wonderful. Someone's been on propranolol since 2012. And it now seems to be causing adrenaline rushes and muscle spasms instead of helping. Are there similar medications that you could suggest to take its place?
Propranolol? Mm. Yeah, so propranolol is one of many beta blockers. Yeah, there are, I don't know, a dozen beta blockers. There's probably half a dozen that I use regularly. As I alluded to, in the different combinations of medicines work for different people. There are ins and outs to using all the different beta blockers. Propranolol was the first beta blocker, and the rap on propranolol was that it would cross the blood-brain barrier, and so that some people would actually find it made them depressed or it gave them nightmares. So subsequent beta blockers were designed not to do that. Some people, particularly if they have racing thoughts at bedtime, want a beta blocker that gets into their brain. But yeah, there are lots of other beta blockers depending on how the propranolol is being used. The other most comparable one is metoprolol. Propranolol is about a 6-hour drug, and so is metoprolol. Then there are other beta blockers that last longer and have other pros and cons to them.
How important is it to have fiber in your diet to retain water?
How important is to have fiber in your diet to retain water? I would say not very. Really, salt is the major thing you need to retain water, and then salt and protein are the two major things that hold fluid in your bloodstream. So if you find that you're drinking water and you're getting puffy, and you think, oh gee, I'm already swollen and puffy, I can't eat more salt because that'll just make me swell worse. That's, again, conventional wisdom, and you really need less water and more salt. And then if you're a vegan or have a very restricted diet, you may need to improve protein. But yeah, fiber, not important for fluid retention in general.
Okay, and the last question, is it common to find in EDS patients that they don't enter REM sleep at all?
Yes, as I showed in this one slide, that this person had essentially no REM. Yeah, there are some medications, including some of the antidepressants, that can delay or suppress REM also. But yes, it's not unusual at all to see that with a person who's just stuck in shallow sleep the whole night and spends little or no time in REM and little or no time in deep sleep. That's, in fact, so common, I would say. Those are the characteristic features of the Ehlers-Danlos associated sleep disorder.
Wonderful. Thank you so much to Dr. Pocinki.
Thank you.